Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for 1 contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. The speakers and planning committee members have disclosed no conflicts of interest. To receive contact hours for this NCPD session, participants are required to attend the webinar and complete the evaluation form, which will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, we will have time for a question and answer session. You'll see on your GoToWebinar control panel that you can send a message through the questions feature. This is where you can type in any question you'd like to pose to the presenter. Be sure to hit send so the message makes it to us. This webinar is proudly sponsored by Colgate-Palmolive. We'd like to thank our speaker today for sharing her expertise. Our speaker today is April Hill. April is a visiting professor at Chamberlain University. She completed her Doctor of Nursing Practice, DNP, implementing oral health education with a nurse home visitation program and has coordinated oral health education experiences with the New York University NYU Nursing Department for nurse home visitors throughout Florida. Dr. Hill continues to promote the integration of oral health education and best practices in maternal and child health programs, working with local public health and providing maternal and child health education. Welcome, Dr. Hill.
Thank you so much. Yeah, hello, my name is April Hilly, and I am a public health nurse. I'm here today to expand on that work that you previously mentioned by sharing some information around children's oral health and making that more equitable, as well as some of the oral health promotion practices that we can incorporate into our work as nurses. So what do we want to get at today's webinar? Today's webinar is going to help you understand how and why early childhood caries is a public health issue, and it's really affecting a significant number of children on a global level. We're also going to look at what the essential risk factors are, and these are things such as the lack of breastfeeding, intaking too many simple sugars, or not getting enough fluoride. And then lastly, we're going to identify opportunities for intervention and how we as nurses can make meaningful, positive impacts to these prevention efforts in practice, as well as explore the causes of early childhood caries. Early child caries is a public health issue, and that's because it's a disease that makes impacts on our health on a global level. So this map here illustrates the regions that the World Health Organization serves, and you can see by looking at it that really it affects all regions. When you see the percentage of people affected, this is represented by the percentage of people who have dental caries, and then the average number of dental caries per person. So for example, the yellow shaded area there in the US, that lets us know that there's an average of between 35 to 69% of 5 to 6-year-olds who have dental caries. And this is data from 2017 and 2018. What this highlights is a need for us to develop global strategies and action plans to tackle early childhood caries, and we can do this by setting shared oral health goals. So before we dive into the details around children's oral equity and promotion practices, it's important to understand some of the background information around what we're referring to when we talk about early childhood caries, what some of the current oral health work has shown us, and also where efforts can be improved. So early childhood caries refers to dental decay in children younger than 6 years old. Dental caries, or tooth decay, is a disease that affects people of all ages, and that's because both your primary and your permanent teeth can get caries. However, it's very common in children. In fact, it's the most common non-communicable disease worldwide, more common than asthma in the United States. We're able to get cavities when we lose the enamel and the dentine on our teeth. And this happens when acids from bacteria in plaque build up after breaking down sugars in the diet. And that's what results in tooth decay. A favorable environment in your mouth will allow remineralization, but if the demineralization rate's quicker, you get a cavity. In the early stages, people generally don't have many symptoms, but advanced stages can lead to pain, infection, abscesses, even sepsis, and the tooth will likely need to be extracted or pulled out. The likelihood of getting caries is influenced by a number of factors like the bacterial and saliva profile of your mouth, and this includes the level of fluoride, how much sugar we're exposed to, and how frequently we're taking in sugar as well. As I introduce some of the burdens poor oral health causes, you'll begin to understand why oral health is gaining awareness as a public health issue and why we're taking measures on both a national and global level. Healthy People 2030 highlights a goal to improve oral health by increasing access to oral health. And this includes preventive services and recognizes that tooth decay is the most common chronic disease in children and adults in the United States. Earlier this year, the World Health Assembly issued a resolution to include oral health on a global health agenda. This urges us to take a closer look at some of our shared risk factors and includes the increased capacity to deliver consistent and quality care on a more global level. We now have a better understanding of how oral health impacts general health as well. When children get their first teeth, these are called their primary teeth. Although there's been some misconceptions around the importance of caring for primary teeth, you might have heard, oh, well, they're just going to fall out anyways. We now know that the health of these teeth can truly impact your adult teeth and even your overall health. We've also found that the things that contribute to poor oral health, like eating a lot of sugar, for example, contributes to poor oral health and overall health, such as illnesses like diabetes. So there's links between the two. If the level of dental decay gets bad enough, it can have some pretty severe system-level consequences. Just the cost of anesthesia to repair teeth can put a financial burden on both families and societies. So think about if you've ever had a toothache. How did that pain affect your behavior? Were you able to sit still very long? Could you concentrate, read a book? How was your mood? Could you sleep very well? Now apply those same behaviors to a school-aged child. There's been studies that show links between lower academic achievement and dental caries. The child may also need to take time off school, right? Because they're going to have extra dental visits, extra procedures, and then they need someone to take them. The caretaker or the parent will need to have to take off work as well. So you can see how this can result in more missed school days and more missed work days, and it can really lead to some burdens on the child, the family, as well as cause some economic burdens as well. So who's at risk for early childhood caries? It's likely no surprise to all you nurses out there that the children in communities who have a harder time accessing resources have a higher prevalence of dental caries. Access problems can come from things like not having enough insurance or not having insurance at all that covers dental, lack of transportation to get those routine checkups, not having enough trained oral health professionals, and even the lack of knowledge of best oral health practices can be seen as an access to knowledge issue. Disadvantaged groups of children who are at a higher risk for getting dental caries include racial and ethnic minorities and families who are living on a lower income restriction. So these groups of people, these groups of children who are most at risk, this applies on a global level. When we look at social determinants of health, such as economic, environmental, societal, and behavioral aspects of dental caries, we understand that these factors play a role in both the cause and the effect. These are things like where we work, where we play, our education, our support systems, the food that we eat, and our health behaviors. So these things are considered modifiable, meaning we can change them. Now, we all know that there's barriers to changing things, but when we look at it on a system level, we can look at how we can improve systems to support things like better health behaviors. These health behaviors are things like what we eat, if we're brushing our teeth twice a day. These are really influenced by our families and our caregivers, so there's opportunity for improvement that nurses can really make an impact and get involved in. So early childhood caries is considered to be preventable because we can change most of the risk factors they result from. Almost all risk factors for early childhood caries are modifiable and related to social determinants of health. On this slide here, we can see factors that can be broken down to influences on the child, the family, the community, and this helps us understand the different levels of oral health impacts. For example, if we look at the child level influences, such as health behaviors and practices, we really know as nurses in our role, we can make a difference with direct care teaching of best oral health practices. On a family level, we understand the importance of including oral health education of caretakers because that role modeling really influences the child. On a community level, we know that promoting a culture that makes oral health a priority is important, and that's because it can improve and sustain best oral health practices. For example, we might look at putting in place policies that integrate oral health on a system level, such as checking when the last dental visit was at a well-child check, or collecting those records at school so we know if we need to make a dental health referral. So where are we now with current oral health efforts? We know that early childhood caries is a global concern, but unfortunately, many of the early childhood programs haven't made oral health a priority, and the programs where oral health should be integrated don't have trained professionals to help mobilize the efforts. However, there's opportunities within these challenges. A key action you need to take as a next step is to identify platforms that can be used to deliver oral health promotion. We can do this by looking at existing programs that are already serving populations at risk for early childhood caries. Now, many countries already have introduced school-based programs to improve oral health. They use toothbrushing with fluoride-based toothpaste, and this is great. But by the time children reach preschool, many children already have dental decay. So we should continue to promote preschool measures, but we need to also look at early childhood programs that serve children when those first teeth erupt. As we understand, we don't have enough oral health professionals to serve these existing programs. We need to also consider oral health training opportunities for primary care teams, and this includes nurses to promote oral health behaviors. Once again, early childhood caries refers to dental decay in kids younger than 6 years old. But when does the first tooth erupt? The first tooth usually comes in around 6 months, and those primary teeth continue to come in until the child reaches about 30 months or 2.5 years old. For a full set of 20 teeth, we have 32 adult teeth. So there's really about a 2-year window of opportunity here that we have to promote oral health practices with families when children are getting those first teeth. Of course, after that time, we want to continue to promote oral health, but when it comes to prevention, the sooner the better, because once again, those primary teeth can impact adult teeth, and once children reach preschool age, studies have shown about 1 in 4 children have untreated dental caries. Early prevention is really key here, and there's some standard best practices that can be taught to caregivers to help them understand how to take care of the teeth, the use of fluoride, the importance of establishing a dental home, which is a routine place to receive dental care in that first year, and how to identify abnormal findings, such as white or brown spots on the teeth. And that way, caretakers can seek out early treatment rather than waiting until later when those caries are more difficult to treat. There's a lot of us nurses out there. There's actually 28 million nurses globally, making up over half of the entire healthcare personnel. We're one of the largest professions, serving people in a broad range of services, and this is from acute care, like working in the hospital, to community-based settings, and even meeting people in their homes. And therefore, we have a lot of opportunity to provide oral health promotion practices and education. Now, as nurses, we may not have already had oral health education yet, but we all have had a pediatric health course in school, and a lot of us beyond that. Some of those concepts that we learned in school and through experience around promoting healthy behaviors can be applied here in the field. For example, we know that children who are between ages 2 to 3 are reaching certain milestones, and that results in some pretty strong-willed behavior. So we can help new parents and caregivers with tips and tricks that promote children's oral health in those toddler years. I have a toddler who's been fighting to brush his teeth, and I remembered, well, he's in this developmental period where he's trying to establish more independence, and I need to give him choices, because if I just tell him, you need to brush your teeth, he's going to say no, right? So I let him pick out a toothbrush, so he has a choice in this. I brush my teeth in front of him to show some really good modeling type of behavior. I put on one of those children's songs that just happens to be about 2 minutes long, and now we make a fun activity out of it. And we do this twice a day together. So you see, as nurses, we not only can help caregivers understand best oral health practices, but we're also pretty good at getting creative when we need to be carrying out these practices in the field. We have good people skills. So how can we get the support that we need to carry out oral health in our role? Thankfully, we don't need to recreate the wheel here, because there's already tools that provide opportunity to integrate oral health into practice. In my experience, these tools have a two-tiered approach, where there's information on both a system level and a direct care level. We need the oral health education ourselves to relay to the caregivers. And we also need the places we work to know that we want to promote oral health and why it's important to do so. So I've categorized this information into actions that we can take on both a direct care and then a system level as well. So now I'm going to highlight main practice and implementation components, but it's really important to recognize that each setting has a unique workflow. So I'll refer you to resources at the end of the presentation as well, as recommend some follow-up education as well. So direct care support refers to processes that allow us to screen for oral health issues, and it helps us identify how to detect early childhood caries, as well as healthy behaviors that promote oral health and the appropriate application and use of fluoride by both systemic and topical use. So next we'll go through each bullet in more detail. When we talk about managing early childhood caries, early detection is really key. In our role as nurses, we can really help caregivers understand how important it is to recognize signs of early carie lesions, because they progress faster in those primary teeth than they do in permanent teeth. If we can help caregivers identify and seek help early enough, the treatment is likely to be painless and less expensive. So in our role, we can help be an entry point to detecting caries and to get connected to oral health professionals, such as a dentist, who will then be able to diagnose early childhood caries for treatment. Also, in those early first years of life, particularly for children under 6, just think about how often children are seeing their primary care providers. These providers also have opportunity to screen and manage early childhood caries and prevent any possible associated problems as well. So what's normal or sound primary teeth look like? And what might cause suspicion when we do a visual inspection of the teeth? So as you can see on the images here, sound primary teeth appear white in color. They're actually more white than permanent teeth, and it's because they have thinner enamel. And they look a little bit smaller than permanent teeth as well. You might see some gaps between the teeth, and this is normal as well because they're holding space for those permanent teeth to come in. It might appear jagged, which is also normal, and that wears away as the child learns to chew and eat. But the images here in A, B, and C, those all reflect normal sound primary teeth. But what we're really looking for are abnormal findings. In early stages of caries, you may see some white spots or lesions, like in image D there. So these spots mean that some of the enamel is starting to break down. In some settings, nurses and other primary care staff may be equipped and trained to visualize all the teeth using a mirror, and they might have really good lighting to check for any abnormal findings. However, if you're working with families in the community and you're teaching caregivers what to check for, you can use visual aids like brochures to show caregivers what early childhood caries looks like, so they know what to look for and they know what to report to their provider or their dentist. Now, as I mentioned previously, some of the jaggedness is normal in primary teeth. If you see indentations on the sides, such as with E, this shows that the enamel is breaking down further. An early cavity has a light brown color, and as the caries become deeper, it turns darker shades of brown or even black. As far as what the child's reporting, symptoms can range from pain in and around the tooth, to just some sensitivity to certain foods like sweets or hot and cold beverages. So the symptoms really vary from child to child, and it depends on the severity. Another practice that's good for oral health, in addition to many other health benefits, is to promote breastfeeding and nutrition. As nurses, many of us are already doing this, but oral health is just another reason to reiterate the importance here. We want to provide parents the support to start breastfeeding and then continue to exclusively breastfeed until the child reaches 6 months of age. If the child's using a bottle, the American Academy of Pediatrics suggests to start weaning from that bottle at 12 months and to quit using that bottle entirely by 15 months because it allows longer exposure of the child's teeth to liquids, and that can lead to dental decay. When foods are introduced, we have everyone providing parents education on what foods are nutritionally adequate. That includes a combination of different foods, such as a diet high in fruits, high in veggies, and low in free sugars. So this helps children get the right amount of essential nutrients that they need. We also want to continue to support parents in breastfeeding, preferably until the child turns 2. And we can do this by connecting resources to lactation consultants, connecting services such as with WIC, and really helping leverage resources that support food security as well and breastfeeding support. And some of us may be lactation certified ourselves as nurses too. We can also check with their insurances and see if they cover breast pump if they want to go back to work. So it encourages them to continue breastfeeding that way. We also want to encourage parents and caregivers to limit free sugars. So free sugars can be found in foods like syrup, table sugar, juices, and honey, as well as any commercial product where the manufacturer adds sugar. It's now known that the amount of dietary free sugars consumed is a primary cause for dental caries. It's recommended that the amount of free sugars should be no more than 5% of energy intake. Fluoride is another great method that's used to lower the risk of dental caries. We can find fluoride in items we use for improving oral health like toothpaste, as well as in things taken in systemically like the water that we drink. So fluoride in drinking water has been shown to be safe and effective for decreasing the risk for developing dental caries. It's low cost, and it has shown to have a positive impact on communities as a public health measure. In fact, it's listed as one of the top 10 best public health achievements of the 20th century. Fluoride can be naturally occurring in water, or it can be introduced through fluoride-based community programs. It was introduced into drinking water in the 1930s, and we saw a positive impact in preventing dental caries from that. And then since then, there's been more studies, nearly 80 across the globe, that have continued to show positive oral health results. The drinking water with fluoride reaches about 350 million people around the world, and this includes populations difficult to reach because it's coming straight to the community water and everyone uses water. The amount of fluoride to be effective is determined by each country's respective public health measures, but tends to be between 0.5 to 1 milligram per liter. And here in the US, that number is listed as 0.7. And community water levels can be found by looking at the CDC site, My Water Fluoride, or local utility providers usually have that information as well. Fluoride was first added to toothpaste about 70 years ago. And since that time, additional studies have shown that it's been an effective method in preventing dental caries. So this works by reducing the prevalence of dental caries as well as the severity of them. So in other words, it can both stop and slow down the progression. Recommended concentrations are between 1,000 and 15,000 ppm in most countries. But for infants and young children who aren't able to expectorate or spit after brushing, the national authorities oversee recommendations for fluoride toothpaste use. In the US, the American Academy of Pediatrics recommends a smear for kids younger than 3, and then a pea-sized amount for children older than 3 if they're able to expectorate. And they should spit without rinsing, without using water, and then the toothbrush should be the last thing that touches their teeth before they go to bed at night. As nurses, when we're working with parents, we should promote brushing teeth twice a day, and that's because it allows fluoride to stay on the teeth for a greater proportion of the day. A fluoride varnish is a topical treatment that some nurses are able to administer themselves, and it can significantly improve children's oral health. This is an application of a varnish to the primary teeth, and it can be provided 2 to 4 times a year to reduce new caries and promote remineralization. And these treatments can be done in the office, like at a dental visit or some primary care visits as well, or even at home, depending on the service. Some programs have received Medicaid reimbursement for this as well. It's a very simple procedure. The varnish is simply just brushed onto the teeth, and then the child needs to wait about 30 minutes to eat or drink anything, and then they're good to go. We can start applying these fluoride varnishes from the time the child has their first tooth, about 6 months. You can imagine how a program that provides home visits could really overcome access issues, because the nurse can bring the treatment to the family, and then the family doesn't need to worry about how to get to an office visit, the time it takes to set up an appointment, or potentially missing work or school. Now that we've covered some direct care opportunities that promote oral health, what can we do on a system level to support these efforts? We need to inform and support policy level actions and rationales for early childhood carie interventions. And we can do that by involving the community and primary care teams in these efforts. monitoring our progress towards shared oral health goals, and advocating for oral health programs and interventions. In order to better engage with local communities, we need to raise awareness that early childhood caries is a public health issue and that it's preventable and what we can do to help. We can promote programs that provide parents education around the importance of oral health on the quality of life for young children. For instance, dental decay can result in other oral health and overall health problems, and then the issues with pain that comes with that, potentially resulting in sleep disturbances and issues with missed school days and lower academic achievement. So it really impacts their quality of life. In our role, we can also provide caregivers with tools to establish healthy habits for their children that start early in childhood. And we can do this by giving them health education on best oral health practices, teaching them how to identify oral health issues that they need to report to their provider, and then helping them establish a dental home, which is a routine place to get dental care. We can also advocate for preschools and maternal and child health services to establish programs that include toothbrushing with toothpaste containing fluoride. This way, children aren't only receiving the information at home, but then it's reiterated at school and through other avenues as well. So before we incorporate oral health into practice, primary care teams need to receive education on children's oral health. Primary care teams can include nurses, midwives, community health workers, oral health professionals, and really we want to include anyone who might be involved as a touch point in the child's care, so that as a community we can all come together to make oral health a priority. And then we all have the same oral health education, we all have a common understanding of the risks and the promotion practices, and we can really increase continuity in care by doing so. In most countries, children under 5 or 6 are seen more by primary care teams and oral health professionals. There's opportunity to incorporate these practices in primary care. Just think about all the well-child checks children are receiving in those early years. Usually children are seen about 13 times from when they're born until the child reaches 5, and this doesn't even count sick visits. This is just the well-child visits. So on a provider level, the oral cavity can also be added to those teeth or head, eye, ears, nose, throat assessments that are already being routinely performed. We also need to monitor and evaluate our efforts on a system level. We can do this by adding oral health practices into policy, such as keeping information around when the last dental visit was with our preschool records and referring kids to a dental home for routine oral health care. Adding toothbrushing with toothpaste that contains fluoride to kids' routine school activities is another step we can take to make sure practices are happening on a system level. And there's also a standardized questionnaire from the World Health Organization that's for caregivers that helps identify risk factors in early dental decay. And there's many other tools available to help equip staff with education, practice, and policy recommendation. There's also a free training through Sigma Theta Tau being offered early next year that will provide information around how to become an oral health equity leader, and you'll receive more information on that at the end of the webinar. Some of the efforts that we can get involved in include promoting oral health within existing primary care services and maternal and child health programs. Once again, most countries have services with primary care that see young children more frequently than oral health professionals, so there's opportunity for involvement. We can also continue to support and promote breastfeeding and nutrition and incorporate that education routinely into our work. So this doesn't actually need to be an additional work task, but these efforts they do have overlap with some of the work that we're already doing. We just need some oral health education and some tools to help integrate it into our practice because there is already overlap there. You can also get involved in policies where we have committees that consider what type of food and drink products are being promoted. Are there many high sugar items being marketed, for example? Taxing products that are higher in sugar is another method to discourage a high sugar diet. We can also look into our community drinking water because it has fluoride, and our local authorities taking steps to make sure that toothpaste with fluoride is affordable for the population. Defying the odds really starts with a great nurse, and early childhood caries is a global public health issue, but we can all take action on oral health promotion and early childhood caries prevention work. So what does this look like in practice? I had the pleasure of overseeing a pilot study in a maternal and child health program that integrated oral health best practices into their standard education that they were already providing. So this program is a program for low-income first-time moms where a nurse is paired with the family and they provide home visits. So the nurse starts seeing the parent during pregnancy and then they continue to see the family until the child reaches 2. They provide parenting education and then they also connect services throughout that time. So for the pilot study, the nurses received an education on maternal and children's oral health practices, and then they promoted oral health at the home visits by providing support around breastfeeding, nutrition education, helping them connect to a dental home, and they also taught parents best oral health practices and how to check for cavities. We administered the nurses a survey before they received the oral health provider education, and then again at 30 and 90 days afterwards to see if there were any changes in what the parent education was that they were providing during these home visits. The surveys were sent anonymously. In the pre-survey, which on the graph here is baseline, 25% of the nurses reported discussing cavity prevention during pregnancy and with families who already had their babies, and 75% said they did incorporate oral health into their home visits. And then at 30 and 90 days, a majority to all of the nurses were discussing oral health with families during both pregnancy and childhood phases, and all the nurses reported incorporating oral health into home visits. So not only did we want to ask the nurses if they were integrating oral health into their visits, but we also wanted to ask the parents to see if the information was getting back to them. At baseline, only 35% reported receiving oral health information and discussed cavity prevention with their nurse, and half reported that they were cleaning their children's teeth twice a day. And then at 30 and 90 days, a good majority had reported receiving oral health prevention information and cleaning their children's teeth twice a day, with about 85% getting that oral health education and 82% cleaning their child's mouth twice a day at the 90-day survey. So I think you really get a good look from these couple slides on how you can implement an oral health education and then put those efforts into practice and see results. Families graduate from the program when the child turns 2 years old. We administered a final survey at that time to the families during their graduation ceremony, and it was asking parents if their children were showing any evidence of early childhood caries, which includes any white or brown spots on their teeth. And the families reported that no, they were not showing any early signs of cavities. Remember, about 1 in 4 preschool-age kids have untreated dental caries. So we would expect some of these families to show signs, especially serving this lower-income first-time mom demographic. So just something as simple as getting information to these parents to say, hey, oral health is important, here's why. And these are some pretty concrete and simple actions you can take to help your child, can truly make a positive impact on the child, the family, and overall, in the long run, the community. So this just goes to show how important our role as nurses is and how impactful we are and where and how we can make a difference. So I thank you all for joining. It's been a real pleasure to share this information with you. I know there's a ton of information here and it'd be difficult to remember everything. So I have included a slide after the reference slide that provides resources for healthcare providers and for caregivers. And then also, I hope you're able to join the follow-up education to become an oral health leader. That's starting in early 2022. And Megan, I'm not sure if there's any information you want to provide for that follow-up education as well.
Wow, this has been really great, and I thank you for sharing all of this. We do have a couple questions for you, if you are willing to answer them. I think you stimulated a lot of great thoughts within our nursing population that are present on the call. One question that I had received is in regards to the free sugar you were talking about. What would be some tips that you would have for parents to ensure free sugar is less than the 5% of the energy intake?
I would really encourage a diet that allows a combination of foods and is really heavily focused on fruits and veggies. And they do have some tools that you can get from WIC as well. I know my child has a plate and it is proportioned to show you how much of each like vegetable, protein, grains, and fruits you should have. And I think that's a really good visual aid to lean on. I just think there's a lot of great resources that you can partner with local communities and local community resources such as WIC to share those resources with them, because it gives a good idea of the proportions that you can have and what you should be eating. And then a way that you can avoid too many of the free sugars is to just look at what is available as well, and where they're living and where they're shopping, and you might even consider getting involved on a policy or system level in the community to look at access, what they have access to. I know at a local WIC program that I worked with, if there were food stamps, for example, those type of benefits, they didn't cover like the foods that were high in sugar. They covered some nutrient-dense type of products. So I think that's another measure to consider if you're able to connect them to resources as well.
Great. Thank you for answering that. And I think it does go to show, the correlation with the social determinants of health, like you talked about in your presentation. Another question we had was in regards to gummy vitamins. The participant says, I think there is a miscommunication amongst parents that they are good gummy vitamins because children are getting the vitamins that they need. But don't the negative effects on the teeth outweigh the benefits? It is so difficult to find kids vitamins that are not gummy. What can we do to overcome this?
Yeah, I think that's really challenging because we want the kids to get the vitamins that they need, and yet at the same time, we have to consider how they're getting those vitamins. So that, I think it really depends, and I think it's kind of an individualized type of case scenario where you need to look at what that child's intake is in regards to food and what vitamins they might be depleted on and how they're getting those vitamins. If they're not going to take it anyway except through a gummy, that might be a great alternative depending on that child. So I would probably speak to the pediatrician on that one because I know a lot of kids just won't take it any other way. So we have to be creative. But you're right in looking at that And I don't know that all gummies are the same or it has the same amount of sugar content as well. So maybe checking the gummies as well. There's other products. I know we have like a powdered probiotic and it has no sugar in it, and we're able to add it to a food and mix it in, and it doesn't even taste like anything. So he doesn't even know what's in there. So that might be something to consider as well. But I really do think you should probably talk to the pediatrician on that one, because we want to make sure that they are getting the vitamins that they need, either through the diet or if they need supplements, make sure they're getting the supplements.
Great answer. Thank you. We do have another comment from a participant, not necessarily a question, but she wanted to thank you for sharing this information, as she did her DMP project on the same topic about 12 years ago and met a fair bit of resistance about the topic not being quote unquote nursey enough. So she's pleased to see that we have made progress. Have you met resistance with it not being nursey enough?
That's so funny that you say that. You know, when we did this project with the nurses in Florida a few years ago, there was resistance from some of the nurses because they thought it was just an additional thing that they had to do. But I think it's kind of the approach that we take, and once you break it down and say, we're already doing a lot of these tasks already, and there's overlap, and when we talk about prevention, if we do a lot of education now, later down the road, we're not going to have to see, sicker patients. So I think it goes to show that if we promote health, it can actually save us work in the long term. So I believe it's the approach that we take. There had been some resistance, but I actually had nurses consult me after we wrapped up the project to ask me for some additional resources because they were still showing interest. So they're still using the tools, and I know that they're using them in practice. But then also with just some of the misconceptions out there in the community, such as, the teeth are just going to fall out anyways. We just need to provide education for the community and on a system level as well, so that we're all on the same page, and we can take a community approach to this, to getting the information out there and actually implementing it in practice. I think after we wrapped up the project, there was great feedback from the community, from the nurses, from the parents as well. But I think in the beginning, there was a little bit of hesitancy. But sometimes we just need to get the word out there first and bring more awareness. I'm glad to see some of these policies and measures being taken on both a national and global level, because I think it can help leverage resources to sustain some of these efforts going forward as well.
Yeah, I definitely agree. Thank you for commenting on that. One question we have is, did the project reach disadvantaged people and immigrants and refugees?
So this project was done in Miami, Florida, and the program participants were part of this nurse home visitation program. So to qualify for that program, they had to be on a lower income restriction. A lot of the participants were undocumented, yes. Because we're partnered with nurse home visitors, it overcomes a lot of those access to care issues because we're able to go directly to the homes. So yes, we were providing this education to some undocumented participants as well. And we really got a lot of great feedback from that population and retention as well in the program.
Great. And I want to ask a question in regards to the fluoride varnish. So should that live in the dental home space or in the primary care space, or either, so that you can ensure that the children are getting this if they need it?
I think it really depends on the setting. We were partnered with federally qualified health centers, and a lot of the participants who were going to the federally qualified health centers were already having the varnish there as a treatment option, and FQHCs provided transportation as well. So we really didn't see a need for the nurses to give the treatment when they were already getting it. But we did see an ability for us to have access to the EHR system to see if they had the treatment and encourage it and bring awareness to it. Once again, it really depends on the workflow, I'd say, and just making sure everybody realizes it's a priority, and then maybe talking to the provider, seeing if their workload is too heavy, and some of the nurses might be able to go take some of those care initiatives from the office out into the community if they're already seeing patients or moms or whoever in the community. They can take some of those tasks off from the provider level and put it into the community. And that creates some continuity in care as well, because then you're communicating with the provider and the dentist and making sure that everybody sees that oral health is a priority. But I would just resort to each unique type of workflow and talk to everybody first before you think, oh, okay, I'm going to go do this. I'm going to go provide all these fluoride varnishes. Really make sure that there's a need for it. Are they already being done? Where are they being done? Are they not being done because there's too many other things that providers are getting sidetracked on? But yeah, I would just take a look at as a system.
Yeah, and to coattail off of that, we have another question regarding the fluoride varnishes. What is the age limit for fluoride varnish?
So even adults can get fluoride varnishes. I think it depends more on the risk, though. So children and adults can get them. You can get them on your permanent teeth as well, but I would look into some other resources to lean on around that. They can go through, when we're talking about children with early childhood caries, we're talking about children younger than 6, and they can have them up to age 6. Beyond that, I would refer out to see what might be recommended, because it might be just like who's more at risk for developing dental decay after that point.
Perfect. And I think we have time for one more question. Any other suggestions on projects to do in the community surrounding oral health?
So once again, we're seeing that in preschools, they've already implemented a lot of oral health type of practices. I do see that a lot of preschools are allowing time to take out of the day for toothbrushing and having that toothpaste with fluoride in that. But where the gap is before preschool. So 1 in 4 kids, when they get to preschool, are already showing signs of dental decay. So before preschool, if there's any type of maternal and child health programs, I think that's where we can really have opportunity to expand on this work, whether that be through nurse home visitation services or bringing awareness in clinics and community clinics as well.
Thank you so much for sharing all of this great information with us today. Sigma is grateful that you took the time to share with our audience, and we look forward to hearing more from you in the future. We hope that you've enjoyed this webinar. As a reminder, 1 week from today, you will receive an email link to the evaluation for you to obtain your continuing professional development certificate. Be sure to check out Sigma's upcoming webinars, podcasts, and resources to support you and your colleagues at sigmanursing.org. Also, previously recorded webinars and podcasts are freely available on the Sigma repository. Thank you so much for joining us today, and have a lovely day.